I got interested in placebos through a converging confluence of interest. The first one was, I would say, first and foremost, my interest in expectation and what happens when people are expecting certain things to happen and how that changes their physiology, how it influences their internal processes. The second one was from my work as a magician, as a former magician, I should say, as somebody who used to manipulate audiences and do all kinds of flourishes and shows and distractions and misdirections. It was very interesting for me to see sometimes that a lot of people took, despite of anything that I said, they would leave a magic show thinking that I have certain powers, although I will tell them time and again that this is all for entertainment purposes and these are all tricks. It was really interesting for me to see how the power of belief, when people really believe that what you say is or what you do is really genuine, how that would override many other things and many other evidence or even information that you get. And then the third stream or the third path that was really influential in shaping my interest in placebos was my interest in deception and what happens when people are deceived, what happens when people are genuinely deceived by an outside party or when they are self-deceived, when they're deceiving themselves for whatever ulterior reason. What placebo effects are, that's a very, very, very difficult thing to define. However, loosely or intuitively speaking, we're talking about the response that people generate in a situation where they're getting something that is not likely to help them because of the chemical ingredient that is known to us to help the situation. So it could be, for example, that the act of taking the pill is helpful to people. Not the actual pill, but just the act of taking the pill. Maybe the color of the pill is helpful. Maybe the size of the pill. Maybe the texture of the pill. Maybe the box from which the pill is taken. Maybe the ad that is associated with the pill. Maybe the fact that you take it 3 times a day as opposed to once a day, and so on and so forth. So there are many effects that are associated with a drug that are non-drug effects. And they could be very subtle. For example, the price of a drug. So we've demonstrated, and it's widely documented in the scientific literature, that if you pay a high price for a particular drug or a very low price for a particular drug, even if the two drugs are the same, and even if the two drugs are zero, in other words, they're doing absolutely nothing in terms of a chemical contribution to the symptoms, the higher or the more expensive drug will have a usually higher effect or an enhanced effect. These kind of effects are considered, generally speaking, as placebo effects. Placebos are not commonly used in clinical care, or at least on the books or formally. They're not supposed to be used in clinical care because it's considered bad form on the part of physicians anywhere, and anywhere in the modern world, at least in the in the Western globe or in Western culture. However, there's another issue here, and that's the ethical issue. When you give a placebo to a patient, even if the placebo works, what do you say? Are you allowed to give a placebo without saying that it's a placebo? Can placebos work when they're not disclosed, and can they work when they are disclosed? These are very tricky, slippery kind of questions that a lot of bioethicists and neuroethicists are thinking about. What we were able to document here, probably for the first time, is that in Canada we have a very unique situation. Whereas a lot of physicians would administer placebos, often they find it uncomfortable or inconvenient to say that they do give placebos. So what they say is that they give subtherapeutic doses of particular drugs, or they would give particular active materials that are not likely to make a difference. But giving subtherapeutic doses is an interesting twilight zone because you are giving a medication, but you're giving a medication at the dose that is not likely to do anything. Alternatively, people can complain about particular disorders or impairments or a particular condition or symptoms, and you would give them vitamins, knowing fully well that the vitamins are not likely to do anything for this condition, yet some physicians would engage in these practices. What we did specifically, and that's part of the reason why it's appearing in the Canadian Journal of Psychiatry, is that we compared psychiatrists to non-psychiatrists. And there's a reason why we're going on with this particular focus, and that's because in psychiatry, in mental health in general, placebo effects seem to be more prominent than in other fields, although there are plenty of other fields where placebo effects are quite prominent. Placebos really have a unique position in psychiatry, mostly because it has been documented recently by multiple independent researchers that, for example, backbone drugs, or I would say pillar drugs in psychiatry, such as antidepressants, are actually no better or performing no better than placebos on most clinical situations that involve, I would say, moderate to mild or light to moderate depression. This is quite striking because most people are not even aware, and they don't fully appreciate the fact that it has been documented that antidepressants and placebos are on par, or in terms of clinical benefit, when it comes to mild to moderate depression. Now, it's also important to understand that there's nothing unique to psychiatry when it comes to placebos. Placebos are also very dominant in pediatrics, they're dominant in dermatology, and they're dominant basically in every field, including surgery, although it is our impression sometimes that in surgery we cannot have placebo effects because it is so, you cut and you remove, but it's very easy to demonstrate, and it has been demonstrated that, sham surgery can sometimes have effects that are equivalent, if not better, than real surgery in particular conditions and for specific patients. It's a very difficult, itchy, touchy-feely kind of subject for the medical community in general. Most of the interesting literature on placebos comes from the social sciences. It comes from sociology, psychology, anthropology, and the such. Most of what we know about placebos and the effects of placebos on behavior modification, on physiology, and even on neural functioning comes from very carefully crafted experiments that mostly are published in journals that are not even indexed by the medical search engines such as PubMed. So what happens is that we really have a disconnect or a potential disconnect between what we know about placebos and the science of placebos and how the medical community thinks and operates in the context of placebos. Placebo effects, doesn't matter how they come about, can be very powerful. And as a scientist and as a person who's trying to be a medical scientist and to make information available to physicians and healers and people who are in charge of curing disease, it is my responsibility to say that when you're able to help a person, I do not argue with the help. I mean, if a placebo is doing it, or if a real, genuine, biochemically active drug is doing this, I really think that that's not the issue for me. For me, the issue is helping people cope with their symptoms and with their diseases.